Good afternoon and welcome to United TV. It's for our Bariatric Friday. It's the best part of the week and the day, so we don't have to be too tense from the other sessions. So one of the reasons that I love healthcare is because this is the place where we can actually help people directly. We have our diabetes sessions earlier at 2 p.m. And a lot of people who don't know what they're going through, we actually try to educate them. And also people, I mentioned to Amanda and Caroline, how many people we diagnose from our bariatric program, from CHRIAS and American Surgery Center. So to help me with our clinical education, I'm going to have Dr. Irgau with me. Dr. Irgau, how are you doing?
I am doing great, Kemal, and I agree with you 100%. This is my favorite time of the week as well.
Honestly, that's what it is. So because this is where I feel like it's more meaningful. So there are individuals who are looking for help, they don't know where to go. This is free, this is available to them live or after it's live. So we want to make sure that we can help our people as much as we can. So Dr. Today we are going to discuss the issue that we see almost daily, why patients drop the bariatric program, especially when they have a huge progress, and then all of a sudden at the end or right before they change their mind. So we are going to discuss this. So I'm going to need your help to guide us, and then I'll have some questions and some statements.
Of course. It's clearly a very important topic. We are proposing bariatric surgery for the treatment of a very serious condition, and that's morbid obesity. And morbid obesity is not only an issue of appearance or inconvenience, it's a real medical problem. Many people may know that with morbid obesity are also associated very serious diseases like high blood pressure, heart disease, diabetes, sleep apnea, and particularly for high levels of obesity, there is no question bariatric surgery is by far the most effective and longer lasting treatment. And yet we have not been able to make a lot of headways in really getting that information out. And even the people who get that information and then after a long consideration, they decide to go through the process. We see that some people actually then don't continue with the process. As you said, I had office hours today, and one of the patients we saw today, the patient that we saw in 2020, well, that patient was ready to start the pre-operative diet, which means they had finished all the multidisciplinary evaluations with the nutritional sessions, with the psychology evaluation, the endoscopy, cardiology evaluation, and yet they did not show up for the surgery. And I asked them what was the reason, and the answer was this was a relatively young person, and they said that they had a lot of input from family members and friends not to proceed with the surgery. And then I said, what has changed since then? Well, they said, they tried to lose weight by themselves and they couldn't. And their weight now is about 40 pounds higher than what it used to be last year for most, right? So they're coming now for surgery with the situation much worse than what it used to be. But this is reality. People have a lot of misunderstanding about the importance of bariatric surgery. Perhaps when these patients were talking to their family members or to their friends, they were looking at bariatric surgery just from the point of view of that person who was heavy becoming thin one day. So in their mind, there is a lot of consideration of whether this is being done for vanity purposes, because they wanted to be thin, because they didn't have the willpower, not really understanding the fact that that person is struggling with that level of obesity at a weight of 328 with a height of about 263. That person has a biologically driven condition, right? And that condition is just going to get worse over the years as it has been demonstrated. But this is reality, and it's important for us to have sessions like this, not only to educate prospective patients, but also their loved ones, to make them understand that the best thing they can do is to encourage them to seek treatment as opposed to discourage them.
So, because of the case conference process that we do daily, we can see the decisions from our patients. Some patients, they're actually returning. So how many patients we have already more than one bariatric initial consult, several. So, and then we actually look at what was the reason why they stopped. There are so many reasons can happen. But one of them is also, I guess, like the maybe misperception of the finances. So, and I, as a devoted, dedicated bariatric resource for our patients, I try certain things that we ask our patients to do, and I mentioned this in the last couple of sessions. The only reason, other than it's helping me, the only other reason that I'm doing this is whether or not if this is doable. To what happens on finances. So I don't normally pay close attention to how much I spend for lunch or dinner, but I know I can kind of get the credit card notifications every time they're spending. So I don't order it, so I don't know how much it costs. Like if you ask me how much this thing costs at this restaurant, I probably know. The only one that I know is $8 because I get those on my own. So now minimum is $12 to $20 average. Like I'm just giving a range for someone to have a proper lunch. But when I'm looking at, and not to be judging, but just the reality, when I'm looking at a patient who's 380 pounds, they don't eat what I eat. They eat two of those $12 to $20 ones, right? So it's not like they're on a diet and they're at 380. So these individuals, they still have this eating disorder, right? So they spend more for lunch. So then when I look at Robart products, so two puddings is $4 or $5 max. So it's, I have to force myself to finish the second pudding. And I do that so that I wouldn't feel hungry for a couple of hours. But I'm pushing, like then at night I cannot eat it. So I'm like, okay, so I need something like real food that is in the last 3 weeks. I'm talking from Monday through Friday. 3 out of 5 nights is salad, just with vinegar, lemon, and olive oil. So, and it's like normally salad will be enough, but this time, like this is too much. I can't finish this. Like I'm forcing myself because I feel like I need a little bit. So now why I'm saying this is because this financial strain is one of the main reasons that many people are saying, "Oh, I cannot afford it." Well, number one, insurance covers for it.
Yeah.
So, while in Delaware, thanks to our great leadership in the government, someone like John Carney, someone like Bethany Hall, who allowed us to have a great Medicaid system, and at 30% right now who's on Medicaid, this is the covered service for our Medicaid population, and the money is not the issue. So that needs to be, I think, needs to be fixed. So when the other reason I mentioned this, Dr. When we put the patient for 2 weeks diet for Robart, just to help them on their liver reduction and stuff, they're like, "Oh, I can afford it." I'm like, that's not true. You are spending way more than what you would be spending for this. So just change that mindset. Just see, just put everything in front of you. I share my own journal, daily log of my food intake and what I do. So do the same thing, and I promise you, you are spending way too much money when you are at 380 pounds on food and everything else. So financial should be really not an issue, but it is one of the issues. Now, if we can kind of briefly talk about the fear of the risk and complications, just to kind of, that's another thing that we hear from our patients.
Absolutely. So there is a lot of myth surrounding bariatric surgery, and that has been borne out by the fact that it's been, for a very, very long period of time, people refuse to believe that obesity really is a disease. In many people's mind, it was something that people have brought on themselves, and that therefore they shouldn't have to have a surgery or medication to be able to fix it. And this myth actually has penetrated so much in our society that even patients themselves end up believing that the reason they cannot succeed is because they are weak, right? I mean, you mentioned earlier on that patients who have a very high weight tend to consume larger meals, and that is because there is hunger that drives this need to take on more energy, despite the fact that they don't need that, and that's part of the pathophysiology, right? It's like having a car that has full tank gas, and yet the indicators suggest that there is no gas, right? And that's the struggle they go through, right? And because of that, for a very long period of time, and to some extent even now, it's been very difficult making people understand that bariatric surgery is an important form of treatment, right? And at the beginning, of course, if you go back at the early days of bariatric surgery, when we didn't have an organized process for really going through it, when we didn't have laparoscopy, yes, there were high complication rates. Just like there were high complication rates for big operations for cancer 20, 30 years ago, right? But over the years, obviously, things have improved greatly, right? So now, things like gastric sleeve or gastric bypass and undertaking laparoscopy, and the risk level is actually comparable to things like gallbladder surgery or hysterectomy or knee replacement surgery, right? But this is something that is very difficult to get through. So people have this conception that, there is this huge danger with bariatric surgery. Of course, like any surgery, the risks are there. But when you compare the risks of the surgery with the risks of staying obese, there is no question people are far better off having the surgery done. But of course, doing research, coming to a center of excellence with experienced surgeons, with programs that have a very long track is actually very important. But that is true for any type of treatment, right? You want experienced people to take care of you. And in bariatric surgery, in our area, we have that. We have been doing bariatric surgery now for over 20 years. We've been doing the really advanced type of bariatric surgery with laparoscopy, and we've introduced into this area about in the last 20 years, right? So does it mean that there is no complications? No, it just means that the rate of complications is very, very important. And that is because experience, now we are able to focus on prevention of complications, and we've been very successful in doing that. The really bigger concerning complications are infection, blood clots, and bleeding. And being able to control this really well because we have excellent preventative methods, essentially. So, yes, it is true, nobody can guarantee that a surgical procedure will never have complications. That is absurd, of course, right? But what we can say for sure is that the complication rate has been really brought down to such extent that the advantages of this treatment by far outweigh the risks.
Absolutely. Now, I was trying to kind of get a couple of our reports ready for us. So, but one thing that I just thought about, how we started our general surgery procedures that are not being scheduled, and then because there are some reason from patient side or some delays, and as I'm going through some of those with our people, this not taking action on a problem, it's very common. People with hernia, people with gallbladder, people with other general surgery complications, they wait. So now, of course, our focus is on bariatric, but I think there's something with the patient behavior and how that is processed, that decision is processed by the patient. So I think we, and including myself, so Mr. Rogers, as the code for those who are watching from Turkey, set out that would be the code. I delayed it.
Mm-hmm.
I went through the unnecessary discomfort and pain more than a year, and I delayed it. I delayed the whole process. I'm like, why will I do that? And then someone at my level with two masters with fellowship from MGMA, a highly educated guy in healthcare, delay the process. So that's why I cannot blame anyone. However, there are other things like gallbladder. It's a huge risk because what's going to happen when you are over 45 and female, gallbladder is going to hit you in the ER when you are least expecting. So same thing with hernia. It's going to get so painful, so it's going to be more riskier as we are doing. And same thing with bariatric surgery as we delay. I haven't seen anyone who lost weight when they come back. Everyone who came back to the program came back with 5 to 12% heavier on their BMI level, period. So we understand there are some, reasons for people to delay, but this is one that you should not be delaying the process. Can we talk about the unrealistic expectations a little bit? What's the unrealistic expectations?
Yes, absolutely, absolutely. So it is obviously very important, and it's part really of our job as we are evaluating and also getting patients ready for the surgery to really clear up, the role of bariatric surgery. So bariatric surgery is a tool. It's a very powerful tool, but it is a tool, which means that we're not asking people to stop worrying about what they need, to stop exercising and just have surgery. What we're saying is that when you diet and you exercise, no matter how long you've done it, you have not seen any results. We're saying keep doing that, but we're going to add surgery. We're going to give you a powerful tool that will make you focus on healthy eating and your exercise meaningful because you will see results. That's what we're saying. But we don't want people to think, okay, you know what? I don't have to exercise. I don't have to eat healthy. I'll just have surgery and then everything will be fine. Absolutely not. So there has to be realistic expectations.
But that's the reason that we share our day-to-day routine.
Yes.
So,
absolutely.
I'm 52 to 54 jacket size. So for those who may not be able to kind of guess. So if you see me, you are not gonna, label me as overweight. I'm 6'1". So the problem is I have to work even harder to not to gain weight. This is that simple. So that's I think maybe like just kind of echoing this expectation where I'm going to have this and then things are going to be the normal things are not that.
Absolutely, so, absolutely. So that is in terms of actually getting the weight loss done. But once you've done with the weight loss, also there is still work to be done in terms of paying attention. In other words, when you take two people and they are eating the same type of food. They are living the same type of lifestyle in terms of their activity level, and yet one person struggles with weight and the other person never struggles. You know that the difference has to be biology, right? And that biology that drives the weight to go much, much higher in the person who's struggling, that biology will still be with them even after the surgery, right? So they cannot afford not to eat healthy. They cannot afford not to exercise. In other words, those things must continue. But the beauty now is that with this, with the procedure itself, they will see results, right? They will feel really vindicated that they can achieve what they've been longing for a long time, as opposed to hitting a wall year after year, which is what has happened when they were just dieting and exercising. So expectations have to be set right, that this is a joint effort between the program providing them a tool that is powerful in the surgical procedure, and them as patients also taking on the responsibility of living a healthy life from them. So setting those expectations right is very, very important.
So one of the things that I think we did at American Surgery Center as a revolution in bariatric surgery is the same day procedure. So historically, our group, when we do cases at the hospital, the requirement was the patient needed to stay minimum 1 night. But since 2018, when we do cases in our surgery center, we are able to discharge our patients 6 to 8 hours from the operation. So someone who has their procedure done by 10, they deem surgery standard by between 4 and 6. So I think this should kind of help for people to understand complications. Also need to understand this is a same-day procedure. So it's not a open heart surgery where you have to kind of stop doing what you are doing for months before you recover. So you are slowly able to go back to what you are doing, and in fact, in 10 days, you're going to see them in the office. Right. So that's kind of like one of the things that we need to really kind of address. I'm looking overall what we have in the last couple of months. So many people don't even give us a reason when they decide to stop the process. That always bothers them. Like, just tell me what happened. So we want to know. Not that we want to force you to do it, but we want to know what happened. So then, because it's something that may be complicated for me, that may not be so complicated for us, we can actually guide them and work with their team. Work with our team. We have social workers, dieticians. Yesterday, I talked to a patient. Yesterday, or was it when you were with me? No, actually, yesterday. I think Alp was with me. I was showing Alp the process on the general surgery case. Then a lab band removal was one of them, and I sent her the YouTube link. Hopefully, she's watching. Her BMI is 52, so she sees one of our surgeons, but she also sees our bariatrician, Dr. Medicine, and she's on medication. She is, the way that I see this, she's gonna get the band taken out, and then she'll be probably 3 months after that. She'll be having a sleeve or maybe the bypass. Most likely sleeve, because she didn't have diabetes or reflux or other issues. I checked her chart. So the problem was, this is why I'm saying this actually, that because this is also not scripted, so hopefully people understand if we have a little bit disconnect, but trying to keep it all together. So one thing that this patient said, hey, I work at night shift in one of the correctional facilities. So I can't do certain things. I cannot take time off. I cannot, she didn't know how much time she needed to take. But then my issue was, I look at the patient with 360 view. I'm like, hey, yes, the medication is okay, but it's not going to be enough. I'm going to have you with the nutritionist. Please, schedule the nutritionist. And she was open to that. So I need you to follow up with the surgeon, because while they're going through this, there are other things that are going to happen. So you need to discuss this with your surgeon. So, and all of a sudden, we had her follow-up appointments. Her nutrition is going to be scheduled, I believe, today. She didn't do her blood work. And then she also now knows that we have the Bariatric Friday available, so she can watch them and then learn more about it. But then I can see why she would be able to coordinate this with that work schedule and not knowing how long she's going to be out. But I think now she has a much better understanding. So that's why communicate with us. And another reason we are discussing this patient, because this patient was seen, I believe, in February. So this is August. Normally our bariatric patient, we are out, we finished process in 8 weeks. So since then, patient is not doing anything. That's not an option. So just communicate with us so that we can find different solutions. That's some of the other help that's needed from our side.
So I mean, that's an important point that you're bringing, right? A person that is juggling also with other priorities in their life. And this is understandable. Of course, we live in a complex society, and the demand on us from different parts, of our lives are intense. And the issue, obviously, particularly when you look at modern obesity, is the insidious nature of the disease and the lack of urgency in terms of its impact on the person's health, right? Like if you have, for instance, a severe attack of gallbladder disease, right? You have pain, and no matter what other priorities you have in life, if that pain is intense, everything else has to stop, and you're going to head to the emergency, right? And you take care of it. Well, Morbid obesity is not like that. It's insidious. In other words, it impacts your health slowly, almost without you noticing. To the extent, come on, that some people don't realize how much weight they have gained because they put off the idea of weighing themselves, right? They put off the idea. They don't. I remember actually a surgeon who was telling his story about, morbid obesity. He was struggling with morbid obesity, and he had bariatric surgery and did very well. But he was just sharing his experience, and he was telling us that he knew he had weight issues, but he kind of didn't realize how bad it was because every day he was adapting to that extra weight by doing something. So he didn't quite feel it.
Mhm.
And he never weighed himself until one day he found himself in an airport cargo area. And he saw a big scale. And he decided to go on. Just say, that's a scale. You should be able to show me my weight. And he went on it, and he was 425. And he almost fainted. He had no idea he weighed points like that. So that denial that is in the mind because it occurs so insidiously, or until diabetes comes up, or until blood pressure medications have to be taken. So people see that, and then the urgency is not there. And that's why we see so much procrastination, really, when we are trying to get patients to understand that there is some urgency in this. And of course, added to that, there is this ambivalence about whether treatment is really necessary or not for morbid obesity because of the stigma that society has, infiltrated in the whole process. People think, I should be able to do it by myself. Maybe surgery is just an overkill for this, without really understanding that one day they will reach a point of no return if suddenly they have heart failure and now their ejection fraction is 20%, and surgery may not be an option if they reach that stage. So
they can get the cardiac clearance.
Exactly. So all these are, very important consideration, and I really applaud the fact that you bring these issues come out, because these are really the meat of the matter, so to speak, when we try to get people to understand that we are dealing with an extremely serious and life-threatening condition.
So, one of the other issues that I see that are unrelated health complications, and in that group, what I see is mainly those patients who are going to have some other surgeries like orthopedic or foot, and it always amazes me that they want to do the foot or orthopedic surgery before the bariatric one. The thing is, many orthopedic surgeons recommend that they should be doing their bariatric surgery and losing out weight so then it can help them to recover from their orthopedic surgery. Well, but yet patient has this mindset, I'm going to get this. That means it's kind of like making a reference to what we said, like, do I really need to have surgery for this problem? But then I need to have a surgery for the orthopedic problem. So understanding of what recovery means. So someone who's more fit is going to recover much quicker from those issues, those problems, than someone who's not. So because mobility is one of the primary factor of the recovery. So if you don't have good mobility, you are going to have issues for every procedure almost. So I guess when I look at these, what I see that we can do. So because these are going to happen, but if I'm able to bring out these patients who are not willing to come out and tell us what they want to do, because during the training I called some, and for whatever reason I enjoy doing it, and they always answer. So I think we need to make sure that they understand the different things that we can do for them. So these are available. It's not that complicated. Chronic, this is one of the biggest illnesses that's going to make everyone's life more miserable, uncomfortable. So that solution is so easy. So other than the personal residence, you need to have this tool to fight this problem, and that's how we can actually help. So please don't drop out. And I'm gonna tell you because we have a horse in the race, so like people who are watching, they will be like, oh, so they wanna do surgery on everyone. No, we wanna do surgery on everyone who has morbid obesity. If they find a solution to fix the problem, be my guest, so that no problem, we are okay with that. But if you choose not to do anything, just like when I see the patient with A1C 12, like today we had one patient, right? We have Dr. Handal add that patient to the schedule for Saturday because patient's A1C is 12.7. You know, that patient is gonna have an emergency visit to the hospital. If it's not today, it's tomorrow or it's next day. So this is all connected, and the best part of this job for us to be able to reach out to these individuals and educate them, and that's hopefully that's what we can do. Not just actually educating, but we also are providing those resources for them. Like not every program has social workers, not every program have 5 dietitians readily available. Not every program is doing case conferences to better understand them. So please reach out to us. Tell us what the problem is, what your work schedule is, what your financial issues are. So we can always, there are always ways to help for those situations.
Yeah.
So Dr. Gad, thank you for joining me today.
Thank
We'll
you.
be back next week with another session, with another topic. Today is tornado and hurricane watch. I don't know how outside is. I haven't been out yet. But hopefully everyone is safe in shelters or in their homes. Please be careful and we'll see you soon. Bye-bye.
Bye-bye.